Before I start, I would like to thank you, the AAO Committee on Conferences, for the invitation to speak today. I would like to introduce myself. I did my dental degree at Chulalongkorn University in Thailand, and I did master's degree in orthodontics at the University of Michigan. I got a diplomate of American Board of Orthodontics. I am now an AAO International Ambassador, and I currently serve as the president of the Thai Association of Orthodontists. I teach part-time at Chulalongkorn University, and I started using clear aligners since 2003. I am an aligners faculty speaker, but I did not receive any support for this presentation. Today we're going to cover 4 contents of this topic: the vertical and anterior posterior relationship, extrusion with fixed appliances versus clear aligners, and we have some sample cases before we conclude the lecture. In this diagram showing major characteristics of malocclusions, the circle represents the 3 planes of space. The circle of malocclusion in anterior posterior or sagittal planes, which are the class 2 or class 3, and the circle of malocclusion in the vertical plane, which are open bite and deep bite. When they overlapping between AP and vertical problem, we represent the pitch orientation. The pitch is the orientation of the palatal plane, occlusal plane, and mandibular planes relative to true horizontal. And we have the movement of this plane in counterclockwise rotation or forward rotation. This will reduce the lower anterior face height and overjet, which is good in class 2, especially in high angle class 2. In the opposite, when mandible rotates clockwise or backward rotation, as it moves down, the lower anterior face height and overjet will be reduced, which is good in class 3 malocclusion. And this is a treatment approach that we're going to talk about in this presentation. Class 3 skeletal components can be any combination of these components. Maxillary can be deficient in the vertical, and this has the indirect effect on the mandible, causing the mandible that might be not as large in size, but causing the mandible to position more forward. So to correct this, surgically, they do the Lerford 1 downgraft the maxilla to correct the deficient maxilla, and this will rotate maxillomandibular complex clockwise or backward. What about non-surgical approach? If we can extrude posterior teeth, we can rotate mandible downward. So this is good in short face height people. Every 2 millimeters of posterior intrusion will result in 4 millimeters of bite closing in the front. This is good for anterior open bite. And vice versa, 2 millimeter posterior extrusion should result in about 4 millimeter bite opening. So the non-surgical approach to increase the vertical is to reduce class 3 jaw relationship, to reduce the need to procline upper incisors and reduce the need to retract lower incisors, for example, lower incisor extraction. What about extrusion with fixed appliances versus clear aligners? Comparison between fixed appliances and clear aligners. Braces mostly give full pull force, but aligners only give push force. And aligner push on either 2 surfaces or on attachments. To have through extrusion, we need the attachment, so the aligner can push on the attachment. So aligners are not good at extrusion, while braces tend to extrude teeth. Let's look at this case that was treated with fixed appliances to extrude molars. 27 years old, came with crowding and crossbite. He has protruding lips and doesn't show any much of the upper teeth when smiles. He has ectopic upper right canine and small implants on the upper left 6, full class 3 molars on the right. In CR, he bites in the anterior teeth and had large posterior open bite. Diagnosis, class 3, low mandible plane angle, short lower face height. Treatment plan, we're going to extract all the third molars except upper left third molars. Extrude upper posterior teeth. I want to extrude upper because he didn't show a lot of front teeth when smile. And rotate mandible clockwise to increase vertical and reduce class 3. And we're going to distalize lower right side with mini screw. So at CR, I made lower 4 and 424 anterior bite plane with thermoplastic. This is to be worn full time. This will increase his posterior open bite even more. In the upper, we bracket all the teeth and use small night tie wire. Lower bracket only 5s, 6s, and 7s, no arch wire. And then we use zigzag elastic to pull the posterior teeth full time except eating. Look at this bite block. It looks like a liner's occlusal surface, right? So we're going to use a liner to do the same thing as this case later. The first row is the bite after leveling and alignment. Then we would like to extrude the whole maxilla teeth because we want to show anterior teeth when he smiles. So I added some composite resin on the small upper left 6 implants to raise his bite, and then we run triangle elastic to the upper teeth and had only 3 to 3 upper wire. In 6 weeks, we got this whole upper arch extruded. The patient was very compliant. So post-treatment, this is how he looked like. Then we have composite buildup, mesial to the narrow upper left canine, and we refer him to have a new crown on the implant upper left 6. The facial change, he has much improved in facial aesthetics. Upper front teeth now can be seen as smiling. We rotated mandible clockwise 4 degrees and increased lower face height 2.5 millimeters from upper molar extrusion. At 2.5 years post-treatment, the bite is stable and he has normal function. So case selection in increasing vertical dimension to reduce class 3, I would use that in adult class 3 anterior cross bite, mild skeletal component of class 3, so we can do non-surgical plan, has short or normal face height. At CR, they have interference in the incisors, and when you have them bite in CR, you can see that they have improved profile and definitely need excellent compliance. Can we successfully extrude posterior teeth with a large amount with clear aligners? Because the reason that we know that aligners is very effective in anterior open bite correction from posterior intrusion. And this is a case of mine that has anterior open bite closed successfully in 8 weeks and even better in 8 months with no incisor extrusion at all. We know that aligner is very good in controlling vertical even when we use class 2 elastic full time to sequential distalize the upper arch in class 2. They maintain the vertical very well because they don't have any molar extrusion with class 2 elastic. And these are because of the bite block effect from the aligner occlusal surface. Reviews on predictability of movement with liners have shown that extrusion with aligners has the lowest predictability. So to extrude with aligner, we need to push on attachment. Or we can do relative extrusion during retraction. Or we can use extrusion with pull force from the elastic. So to extrude with aligners, we need to use one of these 3 modalities. Now, with significant posterior extrusion, I would propose that we use buttons and elastic for the pull force. And because aligner occlusal surface is a very good bite block effect, so I propose that we just section the aligner to have no occlusal coverage. But if we don't have any aligner to control the posterior teeth, we might have problem with controlling arch width and arch length. And we can also use sectional aligners part-time or alternate with the full arch during the time that we use buttons and elastic. And these are sample cases that I'm going to show you. We have 3 cases with bite in centric relation that they have anterior interference with posterior open bite. I'm going to use anterior full-time bite block, including eating, and they're going to wear posterior full-time vertical elastic, except eating. This is case number 1, 58 years old, came with anterior crossbite, concave profile, lower lip in front of E plane. Good upper incisors show at smile, class 3 anterior crossbite and deep curve of spee. In CR, this is how he bites. Incisor contact, large posterior open bite. Diagnosis class 3, low mandibular plane angle, short lower face height. I plan to procline upper incisors. We can retract lower anterior and extrude the lower posterior to level curve of spee, and then we'll have new restoration on the lower right 6 implants because after the extrusion, this implant will be below the occlusion. And this is his plan. I treated this case in 2015, which is the early case of smart track material, which is softer than EX30. So we plan to intrude and retract lower incisors. You can see that I didn't have enough of the anchorage attachment because this is a softer aligners, and we just got this material in 2015. In this case, I procline upper anterior and open spaces distal to the upper canines. This is after the first set. We have anterior interference from initial deep bite, and we also didn't have enough lower incisor intrusion because of the relative extrusion from lower incisor retraction. So after first set, the patient got positive overjet, but he still has this anterior interference and posterior open bite. Now, because we are in class 1 canine, so we're going to extrude the lower posterior teeth to close this posterior open bite. And this is how I set up the plan. I section the aligners in the lower arch, just distal to lower 5s, to extrude the posterior teeth. And in this here, when I use it clinically, I actually cut distal to the lower left canine to get more extrusion of the premolars, and cut the distal surface of the lower light 5. When we want to section the aligner, we don't want to have the distal surface of the last tooth seen in the plan. Otherwise, this area will be covered with plastic, and you have to take the plastic out of the bag and cut the aligners. So we plan to procline upper canines and incisors some more to get out of edge-to-edge bite. And in the back teeth that you don't see in the plan, we use vertical elastic to extrude the posterior. This is after ortho. We did the composite build-up, distal to the upper canines and mesial to the upper 4s. Then patients plan to have anterior veneers and new crowns on the lower right 6 and 7. This is his profile and sephrometics pre and post treatment. We got 2.5 millimeter increase in lower face height and 2.5 degree increase in FMA from the lower molar extrusion. And this is him pre-treatment comparing to post-treatment, 2 years, 3 sets of aligners. At that time, the patient wore the aligner 7 to 14 days per set. And then the third row is the post-veneers and crowns. And the last row is 7 years post-treatment. No retainer for 6 years because the retainer broke after a year and he didn't come back for any new retainers. So no retainers for 6 years, normal function, no TMD sign and symptoms. This is him, smile and profile, pre, post, and 7-year post-treatment. Now, from the previous case, let me give some consideration on trimming the aligners. Which arch to extrude? We have to think about whether we want to extrude the upper arch for more of the better smile line, or we want to extrude the lower arch to correct curve of spee. But you should not trim the aligners on the arch that you have previous extraction or previous IPR, because the spaces will reopen. This is my own case that I had posterior IPR and then I trim aligners after I went to a lecture and someone said you can trim your aligner and have the back teeth settle, or you can trim your aligners and run elastic. So I did. I trimmed the aligner distal to the upper canines and lower 4s, and then we ran zigzag elastic. We got great occlusion, but we had loose proximal contacts. So when someone said you can just cut your aligners to help with the posterior open bite settle, you don't want to believe them. You want to think whether you should cut them or not, because you might have previous extraction or previous IPR. Also, if you have previous expansion, to trim the aligners and use the elastic to extrude, then you roll the teeth lingually, because the teeth will roll when you apply force from the buccal buttons. And like I said, if we have the distal surface of the aligner where we section, the aligner will cover that surface and you have to take it out of the bag to trim it, or you have to tell the patient and teach them how to trim the aligners. So on the picture on the right side is how I do it now. I have the technician cover the distal surface with the gingival tissue so that the area will be trimmed out. And also you can consider alternating sectional aligners with full arch aligners to control the arch length and width. This is a case that has previous premolar extraction and has posterior open bite. So instead of sectioning all the aligners, I only trim it half of the occlusal surface on the lower sixes, and then we use the V elastic, not triangle elastic, because if you use triangle elastic, you could have rotation of upper fives and upper sixes. And this is after the elastic and the aligner trim. Next case is 48 years old anterior crossbite, lower anterior spacing. He has quite reasonably upper teeth shown as smile, but he has his canted lip and canted anterior incisors plane. Eccentric relation, he bites on upper left 1 and 2 and lower left 2. And this lower left 2 over-erupted quite a lot, that is only tooth to contact in the lower arch. So when we intrude this tooth, the bite will close down. So he didn't start with a lot of posterior open bite. Diagnosis class 3, low mandibular plane angle. Actually, he has normal face height. I think he's still able to afford some of the increase in the face height. So the plan is to procline upper anterior, extrude lower posterior, and close lower spaces and retract incisors. This is his plan. Now I section the aligner distal to the lower canines. You can see the gingival tissue covering the distal surface of the lower canines. And the lower canines are not moving, so it can be the retention for this little piece of aligners. I procline upper anterior to open space, distal to the upper canines. I slow down the movement 30% because I'm going to have my patients wear the aligner full time, including eating. So I want them to be able to change aligner more frequently. So I slow down the movement, change every 5 days. In the lower arch, we have lingual attachment that will serve as class 3 bright lamps. You will not bond any composite on your patients. This will just be the bubbles in the aligners for bite ramps. And this is him in action, lower aligners, 3 to 3, running zigzag elastic full time except eating. We have 2 sizes of elastic, 3/4, 2 ounces, or 5/8, 2 ounces, depending on how many teeth on the top and bottom that you hook on the elastic. At stage 18, the posterior teeth start to touch. We have positive overjet. We even have anterior open bite. And I think because the lower left lateral intruded, and we have this anterior open bite. So second set, this is in CO. Now he's out of crossbite. We retract lower incisors because he has this spacing in the lower arch. The lower lingual biram removed, and then we can start rotating the lower canines. This is his finishing plan. So we IPR more on the lower just to reduce the triangle, back triangle, and I leave space distal to the lower left canine because of the asymmetry in the upper arch. This will be for composite buildup. Oops. Post-treatment, we have composite buildup distal to the upper left canine. And he's wearing midline elastic near the end of treatment, and we didn't get there quite yet. So I asked him to wear midline elastic in retainers as well. So post-treatment, actually this case, we didn't get any mandibular clockwise rotation. Actually, we even reduce his face height 1 millimeters. I think this is probably due to the small posterior open bite at start, and also we have some relapse of the posterior extrusion during the two refinements from the bite block effect of the aligners on posterior teeth. This is his bite pre-treatment, post-treatment, and 1 year post-treatment. His facial changes, pre-treatment, post-treatment, and 1 year post-treatment with normal function and retainer just at night. I think he has much improved facial profile. Retention option, we can keep the posterior teeth extrusion and not letting the bite down on the posterior by having the anterior bite plane in the retainers. Or we can alternate the lower clear aligners, lower clear retainers with full arch clear aligner with lower canine to canine retainers. The patient has this small front retainer, alternate with the full arch retainer every night. Because if the molar extrusion relapse, then we're going to have anterior interference. Now the last case, 50 years old, class 3 anterior crossbite, previously extracted upper right 5, crowding on the upper left side and severe rotation on upper 4s and upper 6s. In CR, he has this large posterior open bite. Diagnosis, class 3 low mandibular plane angle, short face height. The plan is to extract upper left 5, extrude upper posterior teeth, IPR on the lower incisors and retract, and we'll try to move upper molars forward with class 3 elastic. This case is quite difficult because in class 3, and you don't have enough tooth mass to have your crossbite correct, so the patient has to wear a lot of elastic to be able to mesialize the upper posterior teeth. This is the plan. So we end the aligner distal to the upper canines. Again, have the gingival tissue cover the distal surface of upper canines. And we slow down movement 30% for the patients to be able to change every 5 days. Even with this small upper canines to canine aligner, I attempt to align and procline upper incisors. So I open a little space mesial to the canine so we can have better plastic wrap on the canine. Also, we have lingual attachments on the lower incisors on the lingual for class 3 bite ramps. This is him in action, upper canine to canine aligner, full time, including eating, 5 days change. We have elastic, 1/8 of an inch, 2.5 hours on the upper 7 to lower 7s. But on the premolars to the canine, we have a zigzag elastic of 3/4, 2 hours on the posterior teeth. You can see that the elastic on the upper left canine will help rotating this tooth. And the lower rows is the patient sending his photos through virtual care. This is at stage 20, so 5 days each, so it'll be 100 days in treatment. Posterior teeth start to occlude. I will do refinement now because the posterior teeth already touch, and I need full arch aligner on the top to align the upper incisors and to retract lower incisors. So we did a refinement. I still leaving the space distal to the upper canines. Now we move buttons from upper 6s from labial to the lingual because you can see that the point of force application on the lingual of the upper 6s will help us rotate the 6s and also can help with the class 3 elastic. This is another set. You can see that now his upper arch alignment is much better. I left the spaces distal to the upper canines. I didn't dare closing that the space because I'm afraid of the too much of the upper incisor retraction. But because the patient is very, very compliant, so we might be able to close the space later in another set of aligners. So this one has 23 stages. Still have the vertical elastic with the buttons. And this is how he wears the aligners. Daytime, he wears lower anterior sectional aligners of the past one. So I gave him a scissor to cut the aligners of the previous one to wear sectional on the lower. Nighttime, he wear the current full arch aligners, and he wears elastic only needed, meaning if he started to have anterior interference, then he's gonna wear more of the vertical elastic. And this is him in progress. This is the most recent photo I have. So we got him out of crossbite, and alignment is pretty much better than previous. Comparing pre and progress, we have 2 degrees of increase in FMA, 1 millimeter increase in lower face height from the upper molar extrusion. So these are the 3 cases I presented today. I think they all have better profile. The first and the third one has the clockwise rotation. The middle one, because of the small open bite at first, then we didn't have much of the rotation. We even have the lower face height reduced. Now, in conclusion, to have the mandible clockwise or backward rotation, I would use it for the class 3 adults, non-surgical, mild component of class 3, short or normal face height, have CR interference that will improve their profile. They probably require minimum in low incisor retraction, and they should have excellent compliance. Clinical techniques use pull force from button and elastic, use anterior sectional aligners for bite block, wear aligner full time. Consider which arch to extrude, upper or lower, and retention, you can use retainers with bite ramps or alternate anterior sectional retainers with full arch retainer. I would like to end with quoting ABO that tools, aligners, braces, they don't make a specialist. It takes education, training, experience to be a specialist. We know that we have 100 years of using brackets successfully, but if you put brackets on the wrong side, then you won't be able to make them work. I would like to thank everyone for your attention and hope you have a wonderful time in New Orleans. Thank you very much. No time for questions. Don't move yourself. You have a minute or what?
We have 2 minutes.
Okay, we have 2 minutes for questions. Them online? Okay. I'll let you take the stage.
Thanks, Dr. Komolpis, for the informative presentation. Any quick question for Dr. Komolpis? We have 1 minute left. All right, this concludes. Oh, you go ahead, please.
Thank you for the great transformation and presentation. Would you mind sharing how did you construct the thermoform lower bite plate? Did you add any extra acrylic or made a bite plane on the lower?
The fixed case?
Yeah, the fixed case.
Yes. Yes, I use thermoplastic acid material, and then I add the clear acrylic on the incisor, in the incisor surface to raise the bite even more. So we have a long distance to extrude the molars. Patient has to eat with them, so they have to be very compliant.
Thank you very much.
Thanks again, Dr. Komolpis. This concludes this lecture here. Thanks everyone for attending.